So good morning, and I feel like Monty Python. So now for something completely and totally different. We're going to move from basic science to a more clinical implementation type of approach. And what I'm going to do very briefly is talk to you about why I think we need to look at additional interventions for PMT-CT, a little bit about primate models, and then studies in human neonates. So I figured most of the people in this audience would be sitting thinking, why are we talking about monoclonal antibodies for prevention of mother-to-child transmission? After all, haven't we solved this problem? So let's talk about where we are in the plan to eliminate new infections. We've made major progress since 2000. In 1999, there were 500,000 infections in that 1 year alone. We've averted 1.6 million infections, a 70% decrease since 2000. However, we've not yet reached the goal of global elimination of transmission. And in 2015, we still had 150,000 new infections, and that's 400 new infections every day. So this slide shows you 6-week and final mother-to-child transmission rates. In green, you see the 6-week transmission rates, and in orange, you see the final transmission rate after breastfeeding cessation. And in the 21 global plan countries, we've decreased transmission from 22% to about 9% in 2015, but there's broad variation, and you can see 3 countries met the less than 5% WHO goal in 2015. And these additional 9 countries would be less than 5% if it were not for postnatal transmission. And if you look at those orange bars, you can see the significant impact of postnatal infection, accounting for more than 50% of all new pediatric infections, and that includes in Malawi, which was the first country to implement Option B plus universal treatment in pregnancy in 2011. So there's still a problem there. So antiretroviral therapy alone is not going to get us to elimination. So why might additional interventions be needed? First, infant infection. In high HIV burden settings, HIV incidence is 3 to 5% per year. Late presentation, 1/3 of African pregnant women don't present until 3rd trimester or even in labor, and that gives you insufficient time to achieve viral suppression during pregnancy, decreasing preventive efficacy of treatment. And then there's difficulty with adherence, especially in the postpartum period, with over 30% of women rebounding, and I'll show you that data. So an ideal intervention would not rely on treatment alone. So this is a study from South Africa, over 500 women starting treatment during pregnancy, all initially virally suppressed. The green is viral load less than 50, blue is 50 to 1,000, and red is over 1,000. And what you can see is that the proportion with elevated viral load increases steadily after initial viral suppression. You can see that increase in red. And cumulatively, by 1 year postpartum, while breastfeeding, 31% of women experienced at least one blip of viral load over 1,000. Additionally, a significant minority of women starting treatment preconception have viremia at their first ANC visit. Another study from South Africa, almost 400 women on treatment who were on treatment preconception, median duration of treatment 2.7 years. At their first ANC visit, 22% had detectable viremia. And of that, 13% had viral load over 1,000. So how does that translate into transmission? So this comes from another study at the same location. Viral load less than 50, transmission practically doesn't occur, 0.25%. 51 to 1,000, transmission 2%. Viral load over 1,000, transmission near 9%, and this is early transmission. So I think we need some new models and potential new adjunctive modalities. And let's look at our holy grail of hepatitis B passive active immunization. So if you take hepatitis B vaccine plus HBIG, you can reduce transmission by 95% in women who have a low hepatitis B viral load, E antigen negative, from 5 to 30% without anything to less than 5% with vaccine or vaccine plus HBIG. However, when the mother is E antigen positive and has high-level hepatitis B viremia, the risk to the infant is high even with immunoprophylaxis. So you go from 70 to 90% without anything to 20% with vaccine to 5 to 10% with vaccine and HBIG. And most recently, last year, they showed that if you combined tenofovir during pregnancy with immunoprophylaxis, you could almost eliminate hepatitis B transmission even in this high-risk group. So I would say for HIV, would the addition of immune-based prevention, such as broadly neutralizing antibody to maternal treatment in breastfeeding infants, allow us to get to elimination? So HIV is selectively transmitted from mother to child. Most of the time, the virus transmitted from mother to child is a single variant, as you can see in this figure from a study in 2008, that only a single maternal variant in the little red box there was transmitted from mother to child. And if you look at the second generation neutralizing antibodies, these 4 studies looking at a total of 46 viruses that were from postnatally infected infants, testing a broad variety of neutralizing antibody, you can see that most of these infant viruses were neutralized by at least one of these antibodies, with the PG9, PG16, and VRC01 being most effective. So let's move to primate studies. Initially looked at first-generation monoclonal antibodies. So these studies looked at pre-exposure administration of high doses of combination of the first-generation antibodies like 2G12, 2F5, 4E10, before or simultaneously with oral challenge with SHIV in the green arrow there. And this protected all monkeys against infection. This is from 3 studies. 12 treated animals were protected, 4 control animals were infected. Post-exposure prophylaxis with these first-generation antibodies, however, it appears to be time-dependent. So when the combination antibodies were given within 1 hour of exposure, it protected against SHIV challenge. But if you administered the antibody 12 or 24 hours post-virus inoculation, it did not protect from infection, although all infants were protected from severe disease and death. All 4 controls died, whereas the other infants did not. So now we've got these new second-generation antibodies. You've heard about them already in the prior talks, that are 10 to 100-fold more potent in vitro than the first-generation antibodies. And primate studies are now evaluating whether these might provide enhanced protection given as PrEP or PEP in the newborn oral SHIV challenge model. So this is a study looking at pre-exposure VRC01 prophylaxis, which protected against oral SHIV challenge. Here, the VRC01 was given subcutaneously 24 hours before challenge. Both control animals, 2 of 2, were infected. Animals that got 20 milligrams per kilogram, both were protected. And the 5 milligram per kilogram animal, 4 of 5 were protected, with the 1 breakthrough infection occurring in an animal with relatively low neutralizing antibody titer. So this study now looks at post-exposure prophylaxis with a combination of PGT121 and VRC06 after oral SHIV challenge. So 20 one-month-old macaques were inoculated orally with SHIV. Broadly neutralizing antibodies were given subcutaneously on day 1, 4, 7, and 10 in 2 doses, either 10 milligrams per kilogram or 40 milligrams per kilogram. Selected animals were necropsied at day 1 to 2, day 14, and then day 28, and multiple lymph node biopsies were done as shown in the little monkey there. So let's look at the lymph node findings. At day 1, let me just point out, the blue is low-level SHIV, the green is moderate, the yellow is high-level, and the red is very high-level SHIV. So if we look at the 2 control animals, you can see that they both had moderate virus in their lymph nodes by day 1. If you look at the 2 treated 10 milligram per kilogram animals, you see there was very low amounts of virus present, and 1 animal had practically no virus. Now if we look at day 14, you can see in those control animals very high levels of virus was found in the lymph node. But if you look at the 2 animals that were sacrificed that received 40 milligrams per kilogram, there was no virus in the lymph nodes found. And if we look at plasma and PBMC viral kinetics, you can see that the control animals in orange all had SIV in plasma and PBMC by day 2 to 3, whereas none of the treated animals, regardless of 10 milligram per kilogram or 40 milligram per kilogram, had virus detected in plasma or PBMC. And then if we move to the 6-month findings, and you look at viral quantification through age 28 weeks, undetectable virus was seen in the 10 antibody-treated infants compared to what you see in the gray historical controls, which is a very big increase by day 1. And that was true in both the 10 and the 40 milligram per kilogram groups. So these results suggest that early passive immunotherapy may not just prevent infection, but could possibly eliminate early viral foci, thereby preventing establishment of viral reservoirs, at least in this primate breastfeeding model of infection. So we are now studying these drugs in neonates, and there's a study in the impact group P1112. This enrolled HIV-exposed infants at increased risk of infection, such as no maternal treatment, or mothers with viremia at delivery in the US, gave 2 different doses, 20 per kilo or 40 per kilo of a single VRC01 dose at birth, and the target here was a trough level of 50 micrograms per ml at day 28. If you look at the pharmacokinetic data, you see that the pharmacokinetics in the neonates was very similar to that seen in adults with a half-life of about 20 days. And if you look at the day 28 mean concentration, while the 20 milligram per kilogram group did not meet the target of 50, the 40 milligram per kilogram group clearly did with a mean of 75 micrograms per ml at day 28. So now a new cohort of breastfeeding infants in Africa is being enrolled, and here a single VRC01 dose of 40 milligrams per kilogram subcutaneously is given at birth, and this is followed by monthly 20 milligrams per kilogram given during breastfeeding for at least 6 months, with the target of maintaining trough levels over 50. This study is ongoing. Safety looks very good. The injections are subcutaneous by slow manual push. The volume is less than 1 ml. It's been well tolerated, no grade 3 or 4 events attributable to the drug. Local reactions were common, more common with the higher dose, but most resolved within 4 hours. So now we have a new antibody that has an extended half-life. If you mutate the antibody and increase binding to the neonatal FC receptor, which is involved in recycling and transpsychosis of IgG within cells, it prevents degradation, increases serum half-life, and in primates, VRC01LS has a 2 to 3-fold longer half-life compared to wild type and increased persistence in the mucosal tissue, most important. And initial studies in adult humans suggest the half-life may be 5 to 6 months or more, with levels 10-fold higher than VRC01. And P1112 is now doing a study in human neonates of VRC01. It's starting in non-breastfeeding infants in the US, giving a single dose at birth, and you can see the doses here. Following that, it will be given in breastfeeding infants with a single dose at birth, a second dose at week 12, again looking at a target of 50 micrograms per ml. So one question that people ask is, will this be affordable if you try to use it to prevent mother-to-child transmission? And this is from a study recently published in AIDS, looking at target costs with a projection of potentially $10 per gram. If you look at the dose of VRCLS in neonates, it's 200 milligrams total for 2 doses. So if the cost is $10 a gram, the cost for prevention in an infant is $2 per infant. So in this rapid summary, I hope I've convinced you that to achieve elimination, we need preventive interventions in addition to maternal treatment. Mother-to-child transmission is generally from a single variant, and most viruses from infected infants appear sensitive to the newly identified monoclonal antibodies. Primate studies suggest that post-exposure prophylaxis can prevent breast milk transmission. We've got phase 1 studies of these drugs underway in human neonates, and I would argue that we need to now move to phase 2B proof of concept in breastfeeding infants in Africa. And I'd like to thank the 11, 10, 12 team for sharing their data. Thank you very much.
Thank you, Lynn. Very interesting presentation. Are there any questions?
Lynn, I like the analogy with the hepatitis B model. I'd like to pose a couple of challenges. If the hepatitis B experience was now inverted, if we were starting with tenofovir, you probably would have a challenge demonstrating added benefit of HBIG and vaccine. And I'm sure you recall that back in the post-076 days, Betsy McFarland did a study through the pediatric ACTG with what I believe was immune globulin, HIV immune globulin.
Yeah, it was HIVIG.
HIVIG, you're right,
yes,
right.
Yeah, I did that study.
Yes, right. That was unsuccessful. It was hard to show a difference because AZT was already doing a good job. So the challenge here will be to show added efficacy, right?
Absolutely, and I think that's what I was trying to argue here, which is that we're not going to get there with antiretrovirals alone. We're not going to have perfect adherence, and we are not going to have, we haven't stopped infection in women. Women are presenting late. So there's still this residual infection of 5% that people with hepatitis B felt was high enough to move to something else. And I don't know that it's true that if you gave tenofovir alone in women with high hepatitis B viral load that you would eliminate hepatitis B infection. You're hypothesizing that, but I don't necessarily know that it's true. And we certainly haven't gotten down to zero with maternal treatment. So I would argue we have enough residual occurring that we need to study something adjunctive. We can't just continue to let 100,000, 200,000 babies continue to be infected every year. It's just not acceptable.
But in the clinical trial with the neonates that you mentioned, you won't offer the mother an antiretroviral treatment?
No, the mothers are all getting treatment.
Okay.
Yeah, no. So when you start studying this, you're going to study it in high-risk infants, right? So these are infants whose mothers haven't gotten it because they've presented late, or they're on treatment and they still have viremia, because that's the place where you might have benefit. You can't study it in the other group. Once you've shown it's safe, you then move to using it as an adjunctive treatment. Everybody should get antiretrovirals.
And in the macaque model, you mentioned an effect on the viral foci, which are present. So would you like to address this question?
I'm not a primate model person. This is a study by Hessel et al. And what when they found small amounts in the 10 milligram per kilogram group at day 1, but out at day 20, at week 28, in that same 10 milligram per kilogram group, there was no virus found. So she was hypothesizing that perhaps they were getting at that early viral foci by giving the antibody early. I don't know if that's true or not, but it's certainly a fascinating thing to think about. You guys actually would be better at addressing this than me.
So briefly, in addition to the Hessel-Hagewood paper, then we had a publication last year where we did an analogous experiment, but slightly different, where we gave PGT121 beforehand and then challenge in a setting we know we get 100% sterilizing protection, and even with known sterilizing protection, we still could detect early foci of virus distally for about 7 days, which then were completely gone by day 10. Yeah. So it appears that the early foci of virus occurs even in the setting of sterile protection, and that those can be eliminated prior to establishment of latency.
Thanks.
Steve?
Right, Lynn. Do you want to speculate on the the size and logistics of the trials to show that this would be beneficial?
Yeah, so you could do the trial among a high-risk group. So you could say, I'm going to only enroll women who present in the 3rd trimester or women who have a viral load, say, over 50, where the risk of transmission could be 2, 3, 4, 5%. Then you'd need about 3,000 babies to look to go, if you have, from 5% to 2.5%, right? And what Dan brought up is absolutely right. When we did the HIVIC study, we only enrolled sick women with CD4 counts under 200. They all got AZT. We thought they'd have a transmission of 10%. Our study was powered to look at a half. The transmission was 5%, you know, and so you can't say it didn't work, actually. There was actually no in utero infection in the HIVIC group compared to 4 or 5 infections in the IVIG group. So that's suggestive, because in that case, the HIVIG was given to the women monthly during pregnancy. So, that's one way to do it. If you enroll people, everyone, regardless of risk, then you probably would need more than that. But 3,000 patients is doable. We just finished the PROMISE study where we enrolled 3,000 patients. It's possible.
Breastfeeding?
Breastfeeding, yes. This is targeted at breastfeeding transmission. You're giving it to the infant at birth, so they've already had their in utero intrapartum exposure. You're trying to prevent that late transmission.
But do you just enroll women that you know are going to breastfeed, or how does that work?
Oh, if you do this study in Africa, they're all breastfeeding.
So
one last question.
Oh, sorry.
Yeah.
I get the impression that you're like high-risk women who we don't think may be adherent or they still have viral loads. With the advances we're making in long-lasting ARTs, would that be a better use of a better intervention to give long-lasting ARTs to the women, and you get the added benefit of protecting the babies as well?
I think that's a very attractive modality. You show me the study that's being done in pregnant or breastfeeding women with those long-acting drugs. It was torture to be able to get these new drugs studied in pregnant women. So you've got issues of, are the pharmacokinetics the same? Because pregnancy changes pharmacokinetics. You've got issues not just of safety to the mother, but you've got issues of safety to the infant, and you've got breastfeeding issues of, does it transfer through the milk? So there are multiple pieces that need to be looked at. My guess is it'll take 5 years or more to get that studied. We could do this study next year. So I would argue we should move forward. Thanks.
Thank you very much. So thank you very much to the 4 speakers for their exciting presentation. And have a nice afternoon.